I'm Bob Ricketts. I'm Director of Commissioning Support Services Strategy at NHS England. I spend most of my time looking at commissioning support services and CSUs, but I've had an interest for 4 or 5 years around commissioning for outcomes and particularly population-based approaches. I wouldn't describe myself as being an expert in commissioning for outcomes, more an advocate, an interested amateur, and I'd certainly strongly encourage you to join Rachel's session. She's one of the few national experts around the different models for commissioning for outcomes, incentives and so on. So that should be a really good session. It's certainly one I'm intending signing into. So what I'm going to do very briefly is just take you through some of the thinking around commissioning for outcomes. There really aren't any experts, and in terms of certainly population-based approaches, whilst there are some sites that are making progress, we've not yet got to the point actually where the evidence, the critical success factors and so on can be evaluated. So it's very much learning by doing. I'm going to start with the context. So hopefully we're all familiar with the forward view, sets out unprecedented challenges for the NHS, rising demand, growing public and political expectations, constrained resources. Crucially, I think, for me, the next two factors. Wherever you look in healthcare, we've actually got outdated, overstretched service models. That's a massive challenge in terms of transformation. And then secondly, one of the things I sponsor in NHS England is right care. It's very evident if you look at the atlases of variation, if you try and use the right care methodology, that we've still got persistent and unacceptable variations in outcome, access and value for money across much of the NHS. So if you take those challenges together, they create the equivalent of a perfect storm for the NHS and particularly for commissioners. Just to touch on demand a bit, and particularly then to try and tie it down to long-term conditions, we're still facing a rising burden of avoidable illness. We've not really made that progress. We've still got 20% of adults smoking, 1/3 of people drinking too much alcohol. Obesity is a major and growing issue, pardon the pun, for the NHS and for the nation's health. And as you know, 70% plus of the NHS budget is now spent on long-term conditions, and that's unlikely, frankly, to decrease over the next decade. And people's expectations are also changing. So a big issue in terms of demand. But we've also got some new opportunities. I mean, we know that we're on the cusp of a wide range of new technologies and treatment, particularly improving our ability to predict and diagnose and treat disease, with some forecasting that in 20 years' time, all cancers will simply be long-term conditions. We're much more successful in keeping people alive longer, but that has a huge burden in terms of the NHS, and we've got more people living with more long-term conditions. The other opportunities, though, new ways of delivering care, key focus of the forward view, dissolving traditional boundaries about actually how we provide care, particularly between primary and secondary, improving the coordination of care around patients and driving up outcomes and quality. So real opportunities, massive challenges, but also a lot of support. So just to flag the IQ program in terms of improving quality, in supporting CCGs to commission personalised care, and then also through commissioning support. We have 9 CSUs, commissioning support units currently. We're just going through a major procurement to drive up the quality of commissioning support, bring in new providers. A key focus in qualifying providers to get onto our new framework is their capability, competence and capacity around commissioning for outcomes. So certainly any commissioner, if they're looking to do something in this area, really ought to consider contacting their commissioning support unit or CSS provider at an early stage. So big challenges, a huge financial challenge. We're losing the battle so far in terms of demand, but a lot of support around, and also opportunities in terms of reconfiguring the system. So I remain fairly optimistic longer term about actually the ability to create a sustainable NHS. So I'm going to focus now down onto commissioning for outcomes and just answer the basic question, well, why bother gearing up to commission for outcomes? Well, it's fairly straightforward. If we're going to deliver the forward view, we need approaches which firstly incentivize high-quality integrated pathways which deliver good quality joined-up care. A lot of work going on around MSK. Currently, Bedfordshire, a very good example in terms of what can be achieved. Secondly, we need place-based solutions with effective co-commissioning. One of the big problems in the reforms has been the fragmentation from having multiple commissioners. NHS England is looking to work with CCGs to co-commission effectively, but we need to move much more to making place-based commissioning a reality. Thirdly, as part of that, we need to make the best use of resources, by which I mean NHS funding, local authorities, communities and users. A phrase I really like is there is only one Leeds pound. Doesn't matter whether it's actually Sheffield, Wakefield or Epsom. There is only one public service pound, and there's a duty on us to actually make the best of that and, crucially, engage users and communities, not just in terms of shared care, but actually what they can bring to the table. We've got to find new ways through new contracting models of rewarding the delivery of the best outcomes for users, carers and communities, and as part of that, we need to take much more seriously the whole issue of social value and how we maximize social value, particularly for communities. Given where we are on long-term conditions, we need to understand and then address the demand risk explicitly in how we commission. If we're going to do that, then my view is that given where we are with models of care and siloed relationships between partners, we need to actually, in fact, get providers together in different new configurations. And some of the best approaches to population-based commissioning for outcomes, like Cambridge and Peterborough, like Bedfordshire, like Staffordshire, are trying to do exactly that. As part of that, absolutely we need to include non-NHS partners and make sure that, particularly if we're looking at options like prime provider, prime contractor, it doesn't end up freezing them out. And then lastly, big issue in this area where I've seen commissioners make a mistake is that there are a range of options in terms of commissioning for outcomes. You need to choose an option that's appropriate to the problem, is deliverable, and takes into account your capacity and capability both as a commissioner and also of your providers, rather than leaping in for a big bang solution and finding halfway through neither party can deliver. But I think there's a really strong set of arguments for why we ought to be taking commissioning for outcomes much more seriously as policymakers and as commissioners. So just actually a quick explanation of what commissioning for outcomes is. It is complex. The best approach I've seen is actually in the narrative on outcome-based commissioning produced by the Commissioning Assembly Quality Working Group. It's on the website. You've got the diagram. It just basically makes the point actually around the role of commissioners and providers in working through the outcomes, getting your contracts right, getting the incentives and reward right. But it's the best definition I've seen, both of commissioning for outcomes and particularly outcome-based commissioning, which is in essence a way of aligning financial incentives across the whole local economy to get the behaviours you want and the cooperation to deliver improved outcomes. It's a very good source, though, for general information on commissioning for outcomes and one I'd refer you to. There are a lot of urban myths around commissioning for outcomes, but in reality it's a spectrum and people tend to often confuse these. So at one end of the spectrum you've got simply embedding outcomes in contracting, so taking the standard contract and then embedding within that clinical and patient-related outcome measures, for example in secondary care, to drive up quality, and then making sure that actually you're linking payment and a much higher percentage of payment much more closely to outcome-based performance. The key experts in that area, and those who've actually published quite widely, are ICOM, which is the International Consortium for Health Outcomes Measurement. Well worthwhile going onto their website. I'll give you the details later. But they've been very successful in working with health insurers in the States to identify clinical outcomes, their equivalent of patient-reported outcome measures, to come up with a narrow set of those, the most important ones, to then actually embed in contracts and then actually use payment mechanisms to drive up quality and patient experience. So well worthwhile looking at that, and you can achieve a lot as a commissioner in terms of improving outcomes and value for money simply by being more sophisticated and demanding in the outcome measures you put in the standard contract. You don't have to leap straight into big projects around outcome-based population commissioning. But at the other end of the scale is a population-based approach. My own perspective is that if you need to drive major transformation, and particularly integration for particular population groups like frail older people, end-of-life care and so on, cancer, and you need to rebalance incentives in your economy by paying for outcomes, then it's a very effective vehicle, but it does actually consume a lot of capacity and resource. So it's something you'd only think about if that's the right solution. As I said, you can achieve an awful lot in improving outcomes and experience simply by taking a much more sophisticated approach to how you contract using the standard contract. So we've got a spectrum, we've got two approaches. I'm going to touch briefly on embedding outcomes. What you see in front of you now are ICOM's standard set for localized prostate cancer. Covers best practice, basically picks out a subset of key outcomes that then can be used to drive provider behavior towards best practice and improve both clinical outcomes and patient experience. It's non-academic. It's been used in the States to drive up outcomes in many areas of hospital-based care, but it's also been used by Bedfordshire CCG. As I said earlier, they've done some really brilliant work, groundbreaking work around population-based outcome commissioning for MSK, and they actually took the ICOM lower back pain outcome set and actually put it into their contract. So that's the contract with Circle. They incorporated the set into the contract. Circle are now expected to deliver on those outcomes, and their financial performance is incentivized accordingly. What it did mean was they didn't have to invent from scratch a set of workable, measurable outcomes. They could actually take the ICOM stuff, which has been developed not just in the States but also tested internationally, and then adapt it, which moved them on enormously. So I would strongly recommend you have a look at the work that ICOM's done, and frankly, actually, if you're looking to drive up quality, particularly in secondary care, just plagiarize it. There is absolutely no point in starting from scratch. I'm then going to move to the other end of the spectrum, which is outcome-based population commissioning, often referred to as the COBIC model. COBIC are a commercial organization who've led the development of outcome-based population commissioning over the last 4 or 5 years, have a degree of expertise. The COBIC model is a particular way of doing outcome-based population commissioning. There are variations on it, but the key components of doing population-based commissioning for outcomes are, firstly and obviously, you must have identifiable and measurable outcomes. You then need to actually be able to link those outcomes to the behaviors you want from clinicians, from institutions, from patients and carers. Having identified your outcomes and your desired behaviors, you then need to incentivize those through payment systems, which may often mean actually, in fact, moving to a full capitation basis. There are variants on that, but incentivizing the behaviors through the payment system. If you really want to drive service transformation and tackle demand, then it's got to tackle and span primary and community and secondary care. Normally, these types of approaches need to be done at scale, which is wider than 1 CCG. It can be done on a smaller scale by introducing a much higher percentage payment for specific outcomes, but normally this is best done and you get the best return if you've got a group of CCGs looking to do transformation for a defined population. It really is based on mature, much more mature and longer term relationships with providers. So you will see folk who are doing population-based commissioning typically talking about 7, 8, in some cases 10-year contracts, and the first 2 years with there being very much a balanced share of risk between the provider and the commissioner as the system beds down. So it's moving away from, if you like, a confrontational, a short-term approach to contracting, to relating to providers, to very much a partnership relationship to improve outcomes and value for money. There are 2 main models for contracting for it. One, lead provider, which is becoming more widely used within the UK. Alliance contracting, which is more of a concept, hasn't been used in anger yet, but has some potential. So just to remind you, the key components, it's population-based or it's major pathways. You could do for older people, which they've done in Cambridgeshire and Peterborough. You could pick up end-of-life care, which Staffordshire have done, or cancer, or you can use it effectively for a major pathway like MSK, as Bedfordshire and large parts of Sussex have done. Key to it is outcome-focused capitation payments, so you're not paying your providers for activity. What you're doing is actually agreeing a capitation for your group of population, your population cohort, and the providers actually then get paid on a capitation basis if they deliver the outcomes. 2 models for contracting, lead provider or alliance. 2 key distinctions from normal commissioning. Firstly, under this type of approach, the providers, not the commissioner, coordinate care planning and delivery. So you're putting the responsibility for pulling together the resources, the care coordination across the pathway with the provider, who hopefully should have more expertise than commissioners, and it saves commissioners having to try to cobble together bits of the pathway. So a key element is providers coordinate care planning and delivery, and that also includes embedding patient choice within that. But then secondly, after you've had an initial phase where you share risk, the provider then takes on much more of the demand risk. And going back to the introduction around the forward view, a key issue for commissioners in many areas, and particularly long-term condition, is shifting that demand risk from them to providers. Doing so fairly, but if the commissioner retains the demand risk but has few practical levers, they're in a bad position. Just to flag, long-term condition year of care commissioning sites, they're actually testing, along with places like Staffordshire or Integration Pioneers, population capitated budgets for LTC cohorts, and also looking at the new contracting and delivery models that Rachel will be talking about in the next session. As I said, there are 2 main contracting models if you're looking at outcome-based population commissioning, and this table just gives you some key attributes and then compares lead provider versus alliance. So lead provider is where you have one provider with whom the commissioner or commissioners contract. That provider will carry much of the demand risk. They'll be responsible for care coordination, and they then actually operate normally through subcontractors and subcontracting arrangements with other providers. Under alliance, you've got a range of NHS and or commercial providers coming together. They then work as part of, if you like, an umbrella contract with the commissioner, but the commissioner retains much more responsibility for managing the relationships between the members of the alliance. In this case, they are all accountable for delivery, and are jointly responsible for any liabilities, but also actually gain any benefits if they actually deliver outcomes and then actually qualify for incentives. But they're two very different models. Lead provider is the one that has tended to be used in most of the integration pioneers, people like Bedfordshire doing outcome-based commissioning. Alliance remains something that in the UK hasn't really been tested, but there is actually quite a strong track record in New Zealand, and Rachel's done some research around actually the pros and the cons of the two approaches. Lead provider does require very high levels of trust between the commissioner and the provider, and very effective partnering between commissioner and provider and subcontractors. Probably can only be made to work where you've already established a significant degree of trust and partnership working within your health economy. It shifts the risk largely from the commissioner to the provider once you've mobilized. It doesn't place a significant burden on the commissioner then to coordinate care and providers, but it is very resource intensive and has long lead times, typically 2.5 years before you get into awarding and mobilizing the contract. Limited proof of concept. Commissioners are doing lead provider, but in no cases have the contracts been in place sufficiently to actually undertake any real evaluation. So there's a minimal evidence base and little evaluation. It does, however, have the big benefit of fitting with a standard contract. It can be accommodated within that, and the NHS England standard contract team can advise on that. Under this model and also Alliance, though, because you're shifting the risk to the provider, because actually providers and commissioners are constrained in resourcing, it does raise the whole issue about actually how do you pump prime change? How do you actually ensure, particularly if you're going to pay your providers on outcomes, that they've got sufficient cash flow and investment to actually, in fact, survive that period of change, reconfiguration of pathways. So one of the things we've been encouraging people to think about, providers and commissioners, are things like social finance, looking at social impact bonds, where the provider is actually able to borrow basically against the delivery of future incomes. Particularly important if you're looking to undertake a major reconfiguration of services where the provider is going to have to invest heavily up front. But looking at Alliance, it's probably an easier approach to implement where relationships within an economy are, if you like, less mature or damaged. It probably gives a better fit with, if you like, NHS culture. It feels less competitive, although I think in reality it's as demanding in terms of the delivery by providers. It shifts risk significantly from commissioners to providers once you've mobilized it, but not as much as lead provider. There's not a significant requirement for commissioners to coordinate care, but when it comes to actually, in fact, holding providers to account, the procurement process, it asks an awful lot more of commissioners. So it's more demanding on commissioner capability. Like lead provider, high resource intensity and long lead times. Very limited, well, virtually no proof of concept in the NHS yet. Sounds like an interesting idea. Has worked in New Zealand, but we've not got the evidence here yet, so there's no evidence base. Big problem is that it doesn't currently fit with the standard contract, but we are looking at that. But that's unlikely to change for the next year or so. And again, like lead provider, I mean, it's an endemic problem with service transformation. How do you actually find the pump priming funding? How do you actually help providers deal with the deferred income implicit in outcome-based commissioning remains a major problem. So both models aren't without their difficulties, but they potentially have a lot to contribute if you really need to drive major service transformation. Just some examples which may be helpful. If you're thinking of doing outcome-based commissioning, whilst you can do a fair amount of desk-based research, looking at what's been published, going onto websites and so on, I think the best thing to do, frankly, is to actually speak to somebody who's actually doing outcome-based population commissioning currently, and I'm sure NHS IQ colleagues can help you in that. Who's doing what? Well, Bedfordshire has done MSK. Cambridgeshire with Peterborough are doing a range of services for older people. That's quite an intriguing one, because what they've been able to do is to use the approach and the procurement to transform their relationship with Addenbrooke's and get Addenbrooke's to actually transform their relationship with local communities and voluntary bodies in terms of providing alternative approaches to care. So it's had a real effect, not just in terms of driving service transformation, but also cultural change, which is worth looking at. Staffordshire is the biggest project currently in the UK, looking to transform services for over 1 million people. So it's all the Staffordshire CCGs, bar one, looking to drive change for cancer, where outcomes are poor, and end-of-life care, where you've got the usual problems around service discontinuity, handoffs, and so on. They're doing that supported by Macmillan, who decided in terms of driving up quality, improving services for the people they represent. They're investing in a number of places in supporting commissioners to improve outcomes, and they're doing that in Staffordshire. So what you've got in Staffordshire is a development partnership between the CCGs, Macmillan, and the local commissioning support unit to bring to bear the quite substantial capacity you need to do outcome-based. 3 approaches to MSK, outcome-based in Sussex. Huddersfield and Kirklees doing some interesting work around how do you actually drive up outcomes and integration in community services, and that's through a lead provider. Slightly older on a smaller scale, Oxfordshire and Milton Keynes around sexual health and substance abuse. They were 2 of the original sites around population-based commissioning for outcomes and were associated with COBEC. And then, of course, we've got the sites for Year of Care commissioning, Southend, Leeds, Kent, Hampshire, Barking, Dagenham, Havering, and Redbridge. And again, NHS IQ colleagues, I'm sure, can actually give you more information on how they're progressing and key lessons. So still emerging, but we're starting, I think, to get to the point where we've nearly got critical mass in terms of enough commissioners starting to do outcome-based for us to look seriously at evaluation and picking up learning. There's an upside to outcome-based commissioning. My own view, and many of the academics, including Rachel, would agree that it gives a big potential to deliver sustainable whole system transformation, certainly to enable you to get better care coordination and planning, much more joined up care and outcomes. It's got a very strong synergy with integration, and therefore you will see a number of the integration pioneers using either outcome-based population commissioning or approaches very similar to it. And as I said, for example, in Cambridgeshire, it has an ability, if there's a reasonable degree of trust in the economy, to actually catalyze and incentivize providers to work very differently. There are some urban myths. There's a view that lead provider isn't actually compatible with choice. That's a nonsense. You just actually, as a commissioner, get your lead provider to embed choice, which you could do through any willing provider for a range of services. And secondly, it shouldn't freeze out participation by social enterprises, voluntary and community organizations, smaller providers. But the commissioner has got a responsibility for making sure that if you've got a lead provider, they treat those smaller providers, those voluntary organizations fairly. There have been 1 or 2 examples with these big contracts with lead providers where SMEs, VCOs have been involved at an early stage and then found life quite difficult thereafter. So I think there's a real onus on the commissioner to ensure fair treatment, and that actually there's a diverse, inclusive approach in terms of subcontracting. There's a big downside. It's very resource intensive. It demands a lot in terms of not just commissioner, but system capacity and capability. There are long lead times, 2 to 3 years. You absolutely have to have crystal clear clarity on the outcomes and the behaviors you want, and if you don't, you will get it wrong. It does require commissioner collaboration at scale, as in Staffordshire, which can be difficult. Crucial to success is effective user engagement from the outset, and it may well require substantial market development, changing the pattern of providers, bringing providers in different ways, encouraging entry by new providers, and that will be extremely difficult if existing relationships are a bit fractious. For most commissioners, I would strongly advise against doing more than one outcome-based population commissioning project at a time, because it is so demanding. If there are other areas where you need to improve outcomes, then I think a more sensible approach is to look at ICOM and actually embed in the standard contract subsets of clinical outcomes, problems, and so on that will drive up performance. But I really wouldn't advocate trying to do population-based commissioning for more than one population group cohort pathway at a time. And there's this big issue on funding double running costs. So fundamentally, I'd say, given the downside, the key question for any commissioner thinking about doing outcome-based population commissioning is, frankly, is it the right approach, or is it likely to be actually, in fact, a sledgehammer to crack a nut? We've been able, with NHS clinical commissioners, King's Fund and so on, to pick out some of the critical success factors around outcome-based population commissioning. The key ones from my perspective and looking at the literature are, firstly, know what problem you're trying to solve. That may seem very obvious, but I've seen a couple of commissioners get things badly wrong because they've not put the effort into understanding the problem and then commissioning the underpinning analysis. At the very least, you would need to do a right care deep dive. Use your commissioning for value packs. They're available free. Be clear what you're trying to achieve. Set measurable and identifiable outcomes. Link those to behaviors. Think about in your own health economy, what are the behaviors you want to change? And then incentivize them, but not just through payment systems. You've got to engage systematically, consistently, and early users, clinicians, communities, providers, and local politicians. Otherwise, you risk getting a lot of noise. You've got a budget for the resources, and frankly, my advice would be to start small. Just finishing up, I will not go through these, but I've put in the slide pack a series of useful sources. Personally, I'd start with the Commissioning Assembly Quality Working Group and King's Fund. If you go on the King's Fund website, there are 4 or 5 really good publications around measuring for outcomes, different contract models, and so on. I've given you the information for ICOM, their general website. It's worthwhile having a look at actually how you would apply outcome measures into contracts. So have a look at cataracts and low back pain. For commissioning for population-based, the COBIC Club are the right place to look at. There's a very good Right Care casebook series by Paul Corrigan and Nick Hicks, which you should look at. Quite a nice one linking outcome-based commissioning to the change model. Again, that's on the website. And there's Rachel's publication recently on contractual models for commissioning integrated care, all worthwhile having a look at. So that's it really in terms of what I wanted to say.